Welcome to the Accidental Experts podcast. I'm your host, Bryce Hamilton. I'm a licensed clinical social worker and a child and family therapist. I have been in practice for over 15 years, and I'm also a mom of 4. So I know the challenges both professionally and personally. I'm so glad that you're here today to grow your parenting toolbox. Please come as you are and be ready to learn. My goal is to make you the accidental expert so that you can raise healthy humans. Hi, guys. Welcome back. I'm so glad you're here today. I have a guest that is going to be talking to us about type 1 diabetes, and it's an importance of being aware and also how to support kids and also how to navigate if your kid has type 1 diabetes. And her name is Dr. Amanda Montalbano, and she has all kinds of certifications. She's a pediatrician. She is a diabetes specialist, and she's also an urgent care doctor. And so she's going to give us all this information. I think this is an important topic for us to get awareness around. With that, let's get to Dr. Amanda.
Thank you. I'm glad we ran into each other.
Yes, I am so glad too. So today you're going to be talking to us about type 1 diabetes. So I know you have a personal story along with type 1 diabetes. Can you share with your story?
Sure. So I'm a mom of 2 young boys and had noticed that my youngest was having a lot of actually behavioral issues and decided to take some time off work to really help him work through all of those issues. And we were making good progress, but I still feel like something was off. Um, and we were taking a train ride to go pick up his brother from his grandparents, and he had peed 10 times on the train. And I'm also a pediatrician by training. And that's when the light bulb went off. And I thought, oh, I know what this is.
Mm-hmm.
You have type 1 diabetes. And sure enough, we took him to his pediatrician, and that's when we got the diagnosis. So type 1 diabetes is a autoimmune disease. We don't have any type 1 diabetes in the family. But as we were chatting about, my husband's parents both grew up in Sicily on an island together down the street from each other. So some recessive genes, I'm sure, are shared within that pool. And they do have some other autoimmune diseases in their family. So he was the first. There's nothing necessarily that you do to become a type 1 diabetic. It's not, you can't control it with diet or exercise. It's very different than the way that we manage type 2 diabetes and the cause of what causes it. So yeah, that's how type 1 diabetes entered my family story.
Yeah. Were you shocked that happened?
Shock is a good word. um, I think I went into kind of treatment mode. My physician brain took over, and it was just like, okay, I know what this is. I know what we have to do. And I just started doing.
Mm-hmm.
And we're 2.5 years now after his diagnosis. And I still don't think that we've fully processed everything that this means for him and for us as a family. So I think shock is probably a good word to use.
Yeah. So tell us a little bit more about diabetes, what it is and what symptoms parents should be looking for, because you said it's an autoimmune disorder. What else do we need to know about this?
Right. So type 1 diabetes is an autoimmune disorder. Autoimmune disorders are when your body, their immune system actually creates antibodies that cross-react to organs in their own body. So instead of fighting off a virus, it starts attacking your own body cells. And in the case of type 1 diabetes, those cells happen to be in the pancreas, and those pancreas cells are making your insulin. So over time, as the body starts attacking these cells and eating it up, your body's ability to produce insulin decreases and decreases and decreases. And what insulin does is when we eat something that has carbohydrates or sugars in it, it releases insulin in order to bring those sugars into the muscle cells, into your brain, so your body can function. So without your pancreas creating insulin, you would die. So In order to treat that, we have to give them insulin through injections.
And so that is something, and so you can't have diabetes type 1 and not use insulin. Is that correct?
That is correct. As it currently exists, there's some really exciting potential treatments on the market, but as it currently exists, you cannot survive without injecting insulin. Even if, there's a lot of different ways that people manage their type 1 diabetes. There's lots of different ways to get insulin into your body, injectable or inhaled, or infusions. But even those who really restrict their carbohydrate intake, they still require insulin.
So what symptoms should parents be looking for? So if they don't know that their kid has diabetes, what are the things that we should be looking out for to be like, hey, that's not typical?
Yeah, so the most common things that we talk about are the T's. So they're thirsty all the time. And now I'm not talking about your 2-year-old who doesn't want to go to bed. It was like, I need a glass of water. I'm too thirsty. No, this is all of a sudden, man, they are gulping down more water intake than you're taking. They're waking up multiple times a night, asking for water. The other T we talk about is toileting. So not only are they drinking a lot, but they're peeing a lot. And as a pediatrician, sometimes we'll see this, that kids, especially in that potty training age, will have a lot of urgency. Maybe they'll have some, minor accidents. But these are, I'm going to the bathroom a lot and I'm peeing a lot every time I'm going to the bathroom. It's not just a little tinkle. We also saw some bedwetting, and that's pretty common. And that's typically because their sugars are running so high at night that their body's trying to get rid of those sugars, and they do that through urinating. Some of the other things that you'll see is like what we saw with behavior or tantrums. They have some major mood swings. And if you think about it, when your blood sugars are dropping, you haven't eaten in a while, sometimes you can get hangry. Oh yeah, this is what we see, right? We see some real hanger. And then on the flip side of that, they can, their sugars can get really high after eating, and then they fall asleep. So the other T is tired. They get really tired. They're fatigued. They need to be napping after large meals. Think about, after Thanksgiving dinner when you would have those big, big meals and everybody gets nice and sleepy. So those are the 4 T's that we talk about that are pretty typical for those who are experiencing symptoms of undiagnosed type 1 diabetes.
So how long, this isn't a one-time thing. I heard you say this is like constant. So like let's say that we're noticing those things where our kid is constantly thirsty, constantly urinating, lots of tiredness and hunger, right? Like how long should we be tracking that to go to our pediatrician and say, hey, this is what I'm noticing?
Yeah. So I would say talk to your pediatrician early. There's some pretty easy screening tests that we can do. That if those screening tests are concerning, there's confirmatory testing down the road. So some real easy screening tests is just to look at their urine. Are they spilling sugar in their urine? Do they have things called ketones in their urine? So that's a quick and easy test. Doing a finger prick, either fasting or after they've eaten, to see kind of those swings in their blood sugars. Those are some pretty easy kind of screening tests. And then also we can do blood tests that can be more confirmatory. There's also now really exciting, if we catch type 1 diabetes early, that means even before they start showing these bigger symptoms, there's treatments that can prevent them from needing that insulin for years at a time. So even families who are at risk, which we haven't talked about yet, but we can, having first degree relatives of somebody who has type 1 diabetes. So if you're a dad and you have type 1 diabetes, your child has an increased risk of having type 1 diabetes, about a 15% chance of developing type 1 diabetes in their lifetime. If you're a mom who has type 1 diabetes, your child's chance is a little bit lower, also depending on when you had your child. So if you were earlier in your life, less than 35, They have about a 6% chance of developing type 1 diabetes. If you're over the age of 35, it's even less. It's about 4% chance. And then if you have a child who has type 1 diabetes, their sibling is also at an increased risk of having type 1 diabetes. So if you have anybody in your family who has type 1 diabetes, there are free screenings that you can do to connect with. I can share those with you, and you can put them in the show notes. But it's a really nice way to have that information, because we can actually do something about it now, and that's really exciting. I will tell you, I had a colleague who had type 1 diabetes, and she found out she had suspicions that her son might have type 1, and got him tested before he started showing real signs, and started doing some things before we had treatments for delaying insulin. Was trying to do everything she could to delay his need for insulin. And at the time, I didn't really understand it. At the time I thought, hey, he's going to need this, like rip the Band-Aid off, get him started. What better mom to have than somebody who really understands what he went through. And now I totally get it. Type 1 diabetes is a chronic illness. It's something that these kids are going to have to deal with probably their entire life. While we're moving towards a cure, it's probably not going to happen. I don't think in my lifetime, maybe in my child's it will. But it's an onerous disease that really affects every minute of every day. And so now I really understand. She just wanted to delay that part of his life as long as she could. So early screening, I'll scream it from the rooftops. There's a reason to do it now. Arm yourself with this information. It's as simple as a blood test that any physician, any clinician can order.
Yeah. Are there, I think I've heard that when you have autoimmune disorders, sometimes they like to group together. So is that true?
That is absolutely true. So we talked about, we don't have any type 1 diabetics in our families on either side. I don't particularly have a lot of autoimmune disease on my side of the family, but on my husband's side, all of his siblings have at least one autoimmune disease. So while my husband doesn't have any, his sisters have hypothyroidism. All of his siblings except for him have vitiligo, which is an autoimmune disease where your body creates antibodies to the melanin in your skin. So if you've seen somebody who has kind of those hypopigmented or white areas on their skin, that's vitiligo. And then we also have, he has a niece, I believe, who has IBD, so a type of autoimmune GI issues.
Yeah.
So we had a lot in his family. I didn't even, consider type 1, to be honest.
Mm-hmm. Well, I think a lot of times we just as parents, we're just going through a day to day, even if we have information, we're just surviving sometimes, right? And so we don't even think about the things that haven't come to our awareness. So it makes sense that you would not have thought this should be on my mind, because it's not something that you have a family history of. But I do think that it seems to be kind of prevalent. And when we were preparing for this call, I mentioned to you that I have more kids in my clinic that have type 1 diabetes than I've ever had. And I found that fascinating because it was more of a rarity before, but now it seems more common. And I think it's not as common as presenting in my practice, but can you talk about that a little bit? Do you think it's happening more frequently?
We know it's happening more frequently. So we know that the prevalence of type 1 diabetes has doubled in the last 20 years. And there's a lot of research going on right now to try to figure out why. Like we said, it's a genetic predisposition. So, you can't change your genes as it is right now. You can't change your genetic makeup. Mm-hmm. So we know that some people who have certain genetic makeups are at higher risk for it. So you can have genetic testing to see if you have those risk factors. I don't necessarily recommend that because familial type 1 diabetes is much less common. It's much more common, like in my case, where it's kind of the first person in the family who has type 1 diabetes. That's the most common way that this kind of plays out
Mhm.
is nobody else in the family has type 1, and then boom. But like you said, it does run together with those other autoimmune. So something to keep in mind, if you have other autoimmune diseases in the family, there's in general, if you have like Crohn's or hypothyroidism, those other autoimmune diseases, it's about a 6% risk for your child, if it's in a first degree relative, for your child to have type 1 diabetes. And type 1 diabetes can develop at any point in life. This is something else that I think T1D breakthrough used to be JDRF is trying to change, because it used to be the Juvenile Diabetes Research Foundation. Everybody thought this was juvenile diabetes. But now over half of the new diagnoses are in people who are adults, which is also
Fascinating.
something that has changed over the last 20 years. It used to be juvenile diabetes, but that's not what we're seeing now in the incidence of new cases of type 1 diabetes. Unfortunately, a lot of these adults are getting labeled type 2 because they're adults. And even as clinicians, that mindset really hasn't picked up, really hasn't changed. Hey, they're fitting the 4Ts still. The lifestyle changes aren't changing their measurements. We should be testing them for type 1 diabetes because their body is not making insulin. And so you can keep giving their body drugs to try to encourage it to make insulin. If there's no beta cells left, those drugs aren't going to do anything. You have to give them that exogenous insulin. So that's something else that we're seeing. Not only is the incidence increasing, but the epidemiology of the disease is changing. Everybody can be at risk now. And so we know that, or we don't know, we have a very good theory that this is virally induced. So again, we talked about autoimmune disease is when your body makes antibodies, and your body makes antibodies anytime it's exposed to a virus, right? So we know that there's some mimicry between those antibodies that are trying to attack a virus, unfortunately also attacks your own body cells. And these are very common viruses. So it's, unfortunately, it is increasing. The current incidence for children is usually around somewhere between 1 out of every 300 to 500 in the general population. For the pediatric population is the current prevalence.
So
And
you said,
we're at higher risk, it can be even lower, like 1 in 100.
wow, yeah. So it can be quite common. So you were mentioning type 2 diabetes, which is a different process. Can you speak to the difference between type 1 and type 2?
Yeah, let's do it. So type 2 diabetes is when, we have the beta cells in our pancreas, it's making it insulin, and it does that in response to the carbohydrates and the sugars that we ingest. So especially in America, our diet is very heavily biased to carbohydrates, and especially those processed sugars, right? And so unfortunately, over the course of a lifetime, those processed sugars, those carbohydrates that we're packing on, our pancreas is constantly responding to that. And eventually it finally tuckers out and says no more. And so over time, it kind of wears out the pancreas. And so in response to that, we see biomarkers similar to type 1 diabetes. So one of the ways that we monitor how well we're controlling the disease is looking at a blood marker called hemoglobin A1C. So some people say HbA1c or A1C. And that is how much sugar molecules are attached to your red blood cells, basically. So how much sugar is floating around in your body that it's sticking to the red blood cells because there's not insulin to push it back into the cells. So we look at that both for type 1 and type 2 diabetes, as well as how well controlled is your disease. And so that's a similar marker for both diseases. But for type 2 diabetes, there's different treatments, right? You still have beta cells. So you can try to, one, decrease the strain on those beta cells by decreasing the amount of carbohydrates or sugars that you're ingesting. So that's your diet. You can try to improve your body's need to pull that sugar into the cells. So that's exercise. So that would be the first step to try to change that trajectory and let your body heal itself. There's also medications that we can give that try to encourage the pancreas to come on, make a little bit more insulin,
Hmm.
as well as encourage the other cells to take in that sugar when they're seeing it, and to try to decrease the amount of free floating sugar sticking to those red blood cells. But eventually, if those things aren't working, then even type 2 diabetics can become insulin dependent.
Yeah, that's a good description. So thank you. That's helpful to understand the difference in those two. So I know, I mean, we're talking about insulin can help us manage diabetes, and I think diabetes can be managed, but I think sometimes parents don't understand the complications of not managing diabetes. So can you talk to us about like what the long-term side effects or outcomes can be if we don't manage our diabetes, like the
Yeah,
type 1 diabetes? Yeah.
yeah. And this goes type 1 or type 2. The complications are very similar because what's happening inside the body, while the reason that it's happening inside the body is different, the complications where we get at the end is the same, right? So we talked about A1C is measuring how much sugar is stuck to those red blood cells because it's how much sugar is constantly floating around in the body. So if you have sugar floating around in the body, whether it's from type 1 or type 2 diabetes, that sugar also sticks to other places in your body, especially your nerves. So you can have diabetic neuropathy, much more commonly seen in type 2 diabetes versus type 1 as a complication. So that's where you feel numbness, pins and needles in your feet, and eventually lose feeling in your extremities, which is a very dangerous thing, because if you have an injury to the skin on your foot, and you can't feel that you have an injury, that can then become an infection.
Mhm.
Diabetics or people with diabetes, unfortunately, have a more difficult time fighting infection because those sugars that are floating around in their body are feeding all those bacteria. So they have a much harder time fighting off infections. And then other nerves, such as in your eyes, you can have diabetic retinopathy because those sugars attach to the nerves in your eyes and can even lead to blindness, as the worst outcomes. And we talked about one of those T's was toileting, right? So one of the ways that the body gets rid of sugar when it's really high in the body is to try to pee it out. And that pee, that urine, is filtered through our kidneys. And so if the kidneys are filtering those high sugars all the time, it can lead to kidney disease, up to and including kidney failure. So you can get chronic kidney disease. So those are kind of the three most kind of scariest complications from wildly uncontrolled, long-term uncontrolled diabetes. And that's why we really try to help our patients, help our kids and adults with diabetes find the best way to manage and keep those sugars down over long extended periods of time.
Yeah. So does that mean, I mean, I think when people think about having diabetes, like as a parent, especially with a child with diabetes,
Mhm.
that it feels like they're scared, right? And that their kid's going to like die, right? Or this worse complication is going to happen. And I know that, we ketoacidosis is something we haven't talked about, but that can be a really, really scary thing for parents. Can you briefly talk about what that is and why that's a problem?
Absolutely. I'm so glad you brought that up because our family story was very different than most kids who were my child's age diagnosis stories. So, kids under the age of 5 are most commonly diagnosed, unfortunately, when they go into DKA, or diabetic ketoacidosis. And that is when the sugars become so high, and this doesn't happen just at diagnosis. This can happen at any point in a diabetic's life. So their sugars can become so high that unfortunately the body is doing everything it can. It's peeing out the sugars, it's trying to shove sugars wherever it can. But eventually, because there's no insulin to use sugars for energy, and the body is starving for energy, it starts breaking down other cells, most commonly muscle cells. And when it does that, those cells rupture open, it releases all that junk that was also inside the cells, and the body becomes acidotic, unbalanced in that base or acid. And once you do that, then it's a real severe critical time, because when it becomes acidotic, you may notice they're breathing faster. The body's trying to breathe off that CO2. It's trying to get out that acid any way they can. So they're peeing all the time. They're super thirsty. They're trying to dilute down all that acid. They're breathing real fast and heavy. And then eventually they'll go into a coma. Their brain just doesn't have enough energy source in order to keep going. And so unfortunately they can go into a coma and die. And so kids who under the age of 5 are at the highest risk for getting to that stage before they're ultimately diagnosed, either in the emergency room or in the intensive care unit. And it's a very scary thing, and it's a very real risk at any point in a person with diabetes life. And so we haven't talked about all this, and I'm sure we're going to get into it, but that goes into some of the fears, I think, in the back of parents' minds, especially as their child goes out into the world, when other people are responsible for their child, whether it's at school or sitters or friends and family members, and as they transition into adulthood and start to take on responsibility of managing this disease themselves, we can talk about that too, and that time of transition. So that's DKA. That's kind of the big, scary high blood sugar risk. We also didn't talk about, and this is less common at diagnosis, but much more common once we get patients on that exogenous or insulin that's supplied from outside the body, is having a low blood sugar. Mm-hmm. And that's much more common once people are diagnosed. They're getting the treatment of insulin, but it's this constant balance of a human, right, with human error, trying to play the role of a body gland, right? Mm-hmm. We don't do it as well, I will tell you. Yes. Don't mess with the pancreas, because that guy is real smart, and let me tell you, you can't do his job as good as he does. Yeah. So unfortunately, there is times when you guess wrong, or you under count, or you overdose on insulin, and you mismatch that insulin need for the amount of carbohydrate or sugar intake. And then their blood sugars, the amount of circulating sugar in their body, drops, mm-hmm. And creates a low blood sugar or hypoglycemia. And the brain does the same thing. It says, hey, hello, I need some energy. I don't have enough. Mm-hmm. So maybe if I lay you flat, it'll come better to me. And so this is, again, where they can lose consciousness, and more commonly with a severe low blood sugar, you'll see seizures. And again, it's because the brain just doesn't have what it needs to continue to function normally.
Yeah. So, I mean, with a diabetic person, their blood sugars can naturally go low too, just by not eating too, right? Like they could also be hungry, or not really?
Well, if they are receiving insulin, so whether that is, and I'm not to get too technical, but there's kind of two different types. For simplicity's sake, there are two different types of insulin. There is a long-acting insulin. So in the United States, that looks like a daily injection, and that kind of keeps their background insulin, right? Because you kind of always need a little bit of insulin in that background, just to kind of continue to feed your brain cells, continue to feed your muscle cells, that just background insulin. Because your body also stores its own sugars and is able to release that as needed. And then you have bolus, that's called basal insulin. And then you have bolus insulin. So that is a more fast-acting insulin that you need to supply the body when you eat meals. So if you have your basal insulin going and you don't eat for long periods of time, then yeah, maybe your sugars get a little bit low. That's less concerning usually than, oh, okay, I know I'm going to eat at this party and they're going to have pizza and cookies, and I'm going to be a good diabetic, and I'm going to give my insulin early, so I'm going to time it just right of when I'm going to eat those sugary foods. My insulin's going to be on board. But then you get to the party and you start talking to your friends and you're running around and you kind of forget. That is when that low can hit, and boy, all of a sudden you're like, I'm really hungry right now. Oh, what's my blood sugar? Oh, it's 45. That's probably why I'm so hungry. And then you correct,
got it.
you eat all the sugar.
Yes, yes, yes.
So it's like a teeter-totter. The best way I can explain it is it's like a teeter-totter. If your blood sugar's low, you need to eat some carbs. If your blood sugar's high, then you need to give insulin. And so it's this constant teeter-totter that people with diabetes are playing in order to try to maintain a nice level, even blood sugar.
Yeah. Which is why we don't want our pancreas to go offline.
No,
We do not.
no, we
Yes.
really don't. We would really like it to keep working. And so
Yeah.
I think that if people with type 2 diabetes really understood, you've got it really good right now. Like, please take care of your pancreas, because the minute you become insulin dependent, your life gets a lot more complicated.
Yeah. Can you talk a little bit about, as a parent with a kid with type 1 diabetes, what does it look like on the daily? Because I know this is also the scary part. Like you were talking about, like the babysitters, the coaches. I mean, like there's a lot of education, medical education, but then also friends, right? Like if your kid has a crash of blood sugar, right, they pass out or they're too high. I mean, it's like we want other people and we can't be with our kid constantly. I mean, but I can imagine as a parent with a kid with type 1 diabetes, it makes you want to be a helicopter parent so badly. I mean, does it?
I mean, I am not a helicopter parent, and my child would not let me be one. So sometimes I say, thank goodness it happened to my youngest, because he's definitely the one who's confident, independent, and really, while my older one is super responsible and a people pleaser and probably would have perfect blood sugars all the time just because he, is that type A type. My younger one is definitely so brave. And, we call them type 1 warriors for a reason. Because these kids go through a lot. I didn't really understand what it meant, I don't think, to have a invisible disability until my kid had a chronic illness. And it really is a disability. He has a severe impact on one of his major organ systems. And so this impacts every minute of every day. And it's going to require a life of making decisions that other people aren't even going to have to think about. Right. And so this is a hot topic right now within the community, that we're very blessed right now that we have the technology that we do. And I want to thank all of the inventors, all the patent holders out there that have led us to where we are today with the tech. So let's get into that. Let's talk tech first before we talk about, sharing the load. Because without the tech that we have, I wouldn't be able to, I think, give him the freedoms and feel as comfortable giving him the freedoms that he does have. So there are like a lot of different ways to manage diabetes. One thing that I think most people think about when they think about checking blood sugars is people pricking their finger and using a glucometer to get a number to say what their blood sugars are being. And for the most part, normal blood sugars per the ADA, the American Diabetes Association, is between 70 and 180. That's the range that we're trying to keep those blood sugars. So when they're pricking their blood sugar, they're trying to see, am I in range, right? Now, it was recommended that somebody do that 8 to 10 times a day in order to have the information they needed to make the decisions they needed to dose their insulin when they ate. That's painful. It's disruptive. And so fortunately, now for those who maybe don't want the burden of doing that, we have things called continuous glucose monitors. And there's a couple different kinds, but for the most part, it is a small device that attaches to the skin, and it has a small wire that inserts underneath the skin and sits there from anywhere from 7 to 14 days, depending on the type of sensor that you're using here in the United States. And what that sensor does is that it sends a Bluetooth signal to a receiver or a smartphone, and gives a reading every 5 minutes without the need of having to prick and know. And so not only does it give us a blood sugar reading, but the great thing about CGMs is it also teaches us what our background blood sugars are doing. So we can start to learn, okay, when I am walking around, I need to maybe just give myself a little more sugar to make sure if I'm going to be doing a lot of walking. If I'm swimming, boy, I just need to stop that background insulin because my body, my muscles are doing enough pulling that insulin in. And you start to learn, okay, what are my needs? What are my adjustments that I need to make in my activities of daily living? So CGMs are life-changing for people with diabetes because it's less invasive, and it gives them information to help them make better decisions in managing their disease. As a parent, it is wonderful because not only is it going to his smartphone, but his iPhone then can send a signal to my phone, to my husband's phone. We have an iPad at the school for the nurse. And so we can share, and for our kind of long-term sitters, we have them also follow his sugars. And so it is just a wonderful piece of technology that helps us create his safety net of a community around him to make sure that if he is going low, we're communicating with who has him and making sure that, hey, have you seen this? Is he eating? Is he okay? And it's been great. It's a beautiful piece of technology. And I encourage any person with diabetes, whether it's type 1 or type 2, to really lean in and use a CGM, learn your number, learn your patterns, and have that safety net available to you. It's just such a wonderful piece of technology. So that's technology number one. And it really does make our life quite a bit easier. Technology number two is when you're first diagnosed, the way that they give insulin to you is via injections. And so those can look like a syringe, old school syringe and vial, or more commonly, now it's a prepackaged, it looks like a ballpoint pen, a very thick ballpoint pen that you can inject through. You can dial up how much insulin you want to inject, and then you inject through that pen. We found that very inconvenient for a child because we had to know what he was going to eat ahead of time, give him insulin for what we planned for him to eat. And then either he said, I don't want to eat that now. And then you're like, you have to eat it. I've already given you insulin. Or in our case, what the trigger was is he ate his meal and then he asked for more apple slices. And I said, sure, bud, absolutely. We're going to have to give you another shot for those. And he goes, that's okay. I don't want them. And that's the moment I knew that multiple daily injections, MDI, these shots were not going to work for our family. Because I really wanted him to not have to make those sorts of decisions. So we have him on a insulin pump. There are multiple different kinds of insulin pumps. We happen to use a tubeless pump, and it's about the size of a floss, a box of floss. Again, it's a tech that sticks to his body and inserts a cannula under his skin. We fill it with insulin before and pair it via Bluetooth to another basically smartphone, or we call it his doser, his personal diabetes manager, PDM. We pair that tech, we stick it on, it inserts his cannula, and then he no longer needs a long-acting insulin. His pump serves both. It drips that insulin in to create that background or basal insulin. And then we can use his PDM to tell the pump, hey, he's going to eat 20 grams of carbohydrate. We can say, use the blood sugar from his CGM, because it can actually read his CGM. He is on a automated insulin delivery system that's closed loop with his CGM.
That's amazing.
So read his blood sugars, as well as the trend in his blood sugars, adjust his insulin dose, and then go ahead and deliver that dose. So there's no needles. There's no need for him to really stop what he's doing. All of this can be done kind of asynchronously from whatever he's doing. He just has to be within Bluetooth range. So those are the two pieces of tech that we use to help him manage his diabetes.
That's amazing.
Yeah. And so it has made our life for the first year. Basically, I was his caregiver. We didn't really trust him to other individuals, just because we felt like that was too much of an onus, really, to put on somebody else, and for safety issues for us. We had a few people that we trusted when we needed to be away, but in general, you're never really away because I'm constantly still watching his blood sugars. I'm the one communicating what numbers to put in and how much to dose, how to make those adjustments, still being, on guard for if he has a low, how many carbohydrates to feed him to get him back up. So even when you're away, you're still really not away as a parent. But now he's in school, he has friends, he wants to go to friends' house. And we are really lucky that, his friends' parents have leaned in and told me, what do I need to know? What snacks do I need to have at the house? How lovely is that? Texting me with pictures of like, hey, he wants to eat this, and here's the nutrition information. How much do I need to dose him? So we're really lucky. And I have now also settled into a life of having a child with type 1 diabetes, and the comfort level that I have in explaining that teeter-totter. And really, with the tech that he has, how I explain to our sitters and our other caregivers in his life is, if you can run a cell phone, you can manage diabetes. And we're lucky that we have the tech available to us that really helps us and others who are responsible for him manage his diabetes, as well as him starting to learn how to do some of those things for himself. And like I said, he's a very confident, very independent little guy. And so really helping him have some of that ownership of it has also, I think, been helpful for himself.
Yeah. Well, and something I find in my practice with the kids that have diabetes is that when they're able to manage their blood sugar and they know what things to eat and they know how to read a nutrition label to get their carbohydrates, it kind of gives them a little bit of control, right, over this disease, right? Like this autoimmune disease. And I think that part at least empowers them a little bit to feel like they have some control, especially when they have this kind of tech out. And a lot of insurance are covering these things, which I think is fantastic, because we need to give kids freedom. They don't need, I mean, I would hate to have to get several shots a day and prick my finger, 10 times a day. I mean, being poked 6 times a day would be awful, right? Like thinking about the meals and the snacks and oh my gosh, it would be exhausting. And so I think it is good for them to share the responsibility, right, as they're aging into that. And it gives them some power over that. And I think not being scared as the parent, like obviously it's so easy to say that, but educating yourself so that you understand what it is, because when you understand, it's not as scary because you do have some power. We have carbohydrates, we have insulin, right? Like we can do this. And the more that you are showing your kid that this is like, we can do this, we can totally do this, the more that they're going to feel like, okay, this isn't like a death sentence. Because I think that's the part is like, I mean, anytime your kid's diagnosed with something, like the first thing you think is like, oh my gosh, this is going to change your life, which sometimes it does, right? I mean, in my house, we have all kinds of diagnoses. And so we're navigating all kinds of things. But like on the autoimmune front, we have celiac that is in our family. And so that is something that is also an autoimmune disorder. And so it does, I think, this invisible disease, because it's like you can't see it on the outside. People will be like, it's not that big of a deal. Just eat this piece of bread. And it's like, oh my gosh, like, no, like you just like, you can't, right? And it's like, oh, just like a little piece. And I'm like, or they'll say like, how about cheating, right? Like in these things, when we're taking care of our bodies, there's no cheating, right? Like it's that we have to take care of what we have. But I think just empowering our kids and ourselves with information and not being afraid to talk about it. And this is something that people do want to support us with, I find in the community. Like people do want to know, and our kids' teachers want to know, and the school nurse wants to be educated, and the principal and the friends' parents and the friends, right? Like more people that have the information, it feels less of a burden that we're carrying by yourselves.
Yeah. And I think we're really lucky in the school that we're in, that his school nurse and I are in almost constant communication, I feel like. But we have such a great relationship. She totally gets it. She gets that diabetes is not a black and white disease. You know, we're also very lucky that our school has an RN every day, the everyday operation. And that's not the reality for the vast majority of schools out there. And I want to recognize all of those parents who are trying to navigate back to school right now and navigating the tech. You know, the Department of Justice has even weighed in on this, that schools will follow CGM sugars, that this isn't an option. This is the child, according to the ADA, American with Disabilities Act, this child has equal access to be safe at school and get an education just as everybody else does. And if the child has the tech to keep them safe, the school will follow those. So props out there to the DOJ for weighing in on that. That was a fairly recent court case that went up that they weighed in on. But that's not the reality for a lot of, I know my fellow T1D moms and dads out there who are really advocating for their children and advocating to keep them safe at school. My heart goes out to them, and I empower them with all of the things that the American Diabetes Association has, that type 1 diabetes, T1D or type 1 diabetes breakthrough puts out. Please reach out to your advocates because they're there for you. But we are very lucky. She gets it. You know, the school orders may say, if this number, then give this many grams of carbs, but it's not that easy, unfortunately. You also have to take in, okay, what is his trend of his sugar? What activity is he getting ready to go do? Does he, you know, are they having some sort of special assembly today that he's going to be really excited about, and his adrenaline may drive up his sugars? Like, it's just so not that easy, unfortunately. But like you said, if you back away from that and just remember this, all this is a teeter-totter, and we have the ability to treat both sides, right? So we're going to try our best to take in all the information that we have and make the best decisions that we think we can make. But at the end of the day, if we miscalculate, we have the ability to adjust. And that's one thing that we're really lucky with him on an insulin pump, is that we can make this adjustment and not have to go ahead and do another injection. Because unfortunately, once you give insulin, you can't take it back. All right. It's a medicine. And so, but we do have the other side of it is, you know, you feed him sugar. It's funny. We got about a year into this diagnosis, and I think I felt like my kid was the only kid who was like, no more gummy lifesavers, no more fruit snacks, no more chocolate. You know, it's one of the few kids who was like, I'm so over this. So finding all those different low snacks and rotating them through so they don't get old. That's just another piece of this. Another piece that we navigate is trying to get creative with those fast acting glucose and make sure that he, you know, because as well as when their blood sugars are really low, they know they need it, but sometimes their brain just isn't online. And so really having to encourage them that, like, buddy, here's a straw, suck down the juice. It can get scary when you hit those lows, and it is a reality. You know, this is a life and death situation, and so, like we talked about with those invisible diagnoses, some people sometimes were like, oh, whatever, you know, I know he has cell phones that he carries around, and you know, sometimes he has to eat some fruit snacks or whatever. But it's like, no, like, I really need you to lean in, and I really need you to hear, if you're seeing him lay his head down on his desk, that's not this kid. The first thing you need to do is say, what's his blood sugar? And so leaning in and teaching those cues, I think, is really helpful.
Yeah. Well, and I think I had a babysitter when I was a kid who had diabetes, and her name was Tracy, and I love Tracy. She was the best babysitter, but she was also a neighbor. And I remember back then, I mean, because I'm 40 now, so like back then, we didn't have either of these tech devices, and my parents would be like, okay, so if Tracy goes down, right, we have orange juice in the refrigerator, like try to turn her on her side, like is like all these things for a little kid. And we're like, she's the babysitter supposed to be taking care of us, right? Like, but we were all like medically minded. Like we loved Tracy. We would do anything for Tracy. But it was like one of those things where it was like really scary. And I'm thankful now that we have more things to monitor kids. And thankfully, nothing ever happened to Tracy. But Tracy is funny because she loved the candy in our house more than any other person ever. And she would be like, "What candy you guys have?" And she would be the candy connoisseur. But I remember that from her. But I think she would get like low. And so she would be like, here's a fast way. But she wasn't telling us that that's what she was doing. We're like, Tracy loves candy. Okay. So how do we support kids with type 1 diabetes? And how does the community support kids with type 1 diabetes? So, as a mom who doesn't have a kid with type 1 diabetes, what should we know about this?
Um, I think like any parent, like any kid, give grace, right? And that goes for everybody. Like it doesn't matter who you are, what diagnosis you have. We're all just trying to make it the best we can out here, right?
Yes.
So I think across the board, give grace. That there's a study out there that said that people with diabetes are making about, on average, 180 decisions a day to help manage their diabetes.
Wow.
That's on top of like just getting up, brushing your teeth, combing your hair, right? Like, and there is some challenge to that number now that we have the tech that we have. But I would go to say, I mean, not only am I thinking about, oh yeah, I'm putting in how many grams of carb it is, but I'm thinking about so many things. Parents with kids with diabetes, we're making sure, okay, we're going to soccer practice. Did I pack the lows? Is his sensor going to expire while he's at practice? How much insulin does he have on board? Do I need to pre-treat with some carbs because I know he's going to be running around and he's going to go low? Oh, I actually have a phone call in the middle of practice. Who else do I have? Does this coach know? Does he know how to recognize, hey, he's not keeping up with the other kids and he's outside his range for his Bluetooth? We should probably check his sugars. Like there's just so many decisions that parents with kids with diabetes are trying to take into consideration before they send their kid out into the world. So just having an extra set of eyes is always really helpful. We're not going to feel, I mean, we welcome those extra set of eyes of like, hey, I noticed Gio is just sitting on the pool and not playing with everybody. Is he okay? Oh, you know what? He's blood sugar is okay, but he's dropping rapidly. Thanks for looking out. Those extra set of eyes is really, really helpful. Leaning in and just being curious instead of just relying on the fact that somebody else is going to take care of it. That's been a real heartwarming aspect of my friend group here, my neighborhood here, who, what snacks can we keep in? A big thing for us is like a lot of kids, we don't let our kids just have juice unless we're treating low. And so, but I know for a lot of other families, they keep soda and juice in the house. And so one thing is like, actually we do, non-sugar containing drinks. So if you really want to do something, having like Gatorade Zero or, flavored bubble waters or whatever else as an option, that would be really cool that he could have what other people are having, just making sure that it's sugar-free.
Yeah.
But if he is going to participate, let him participate and we'll dose for it. And not everybody manages this way. Some people really want to manage their diet, even their type 1 diabetes, with a strict diet. So maybe they do low carb or keto with their type 1 diabetes and manage their insulin needs differently. And that's okay. But I would say the majority of parents who have kids with type 1 diabetes, they're just trying to adjust the kid's insulin needs to a typical diet. And, we want him to be part of the celebrations. We want him to have the cupcake like everybody else. Please don't wipe off the icing and make him different. Like, we'll dose for it. It's okay. As long as I know about it and plan for it. Oh, I know one thing is telling us ahead of time what's going to be at the parties. That's been really helpful. So knowing, hey, we're going to have a sheet cake, or hey, we're going to have cupcakes, or hey, we're planning for pizza and cupcakes before swimming at the party.
Mm-hmm.
That is so helpful for us. So we know ahead of time to think through, okay, he's going to eat before he swims. How do I make adjustments to that? Let me Google real quick what the carbohydrates are in a Hy-Vee cupcake with purple icing,
Mm-hmm.
right? So I can try to match it the best I can.
Yeah.
Um, those things are really, really helpful. And in today's day and age, prepackaged snacks are really nice because the nutrition information is right on the back. So those little things can be really helpful for a parent who's trying to take in a lot of different information and make the best treatment decisions. I think those are probably the most helpful things.
Yeah, that's great information. And so what do you want parents to take away from this conversation? We kind of downloaded a lot of information to both parents with kids who have type 1 diabetes, but also those without. What do you want parents to take away?
I would say trust your gut, especially if you're seeing signs and symptoms of behavior change, diet change, weight loss, any sort of like, if your spidey sense as a parent is going off, please talk to your pediatrician early and say, could this be diabetes? Because, while pediatricians and family physicians and other clinicians may have been trained, oh, yeah, the four T's, and to think diabetes, kids don't read the book, right? And they show up in a whole bunch of different ways. In our case, since our family is a fairly low carb household, we actually think that my youngest was honeymooning, which means his pancreas is kind of sputtering and like kind of working for about 3 years before his diagnosis was actually made. So just say the words. Could it be diabetes?
Mm-hmm.
How can we check for that? I heard that there's some blood work tests looking for the antibodies. Can we test for that? Just ask, get curious, and have those conversations early if your spidey sense is going off. Or if you have some autoimmune disease that runs in the family, talk to your pediatrician about, or your clinician about, hey, we want to get the family tested. We have autoimmune disease in our family, in our household. We want to get everybody tested for type 1 diabetes autoantibodies. We want to know ahead of time. We don't want anybody to end up in the ICU or in the ER in distress. We want to be armed with that information ahead of time.
Absolutely.
So just talk to your clinicians. Say the words out loud because
Mm-hmm.
they may not be thinking it, and they need to know your concerns.
Yeah. I love that advice to like advocate for your kids because we know our kids best, truly. And even if it's not, right, you say, hey, could this be diabetes? Could this be type 1 diabetes? And they run the lab work and they're like, nope, everything looks great.
That's
Like you've lost nothing there, right? Like
absolutely not.
yeah.
And thinking back on it now, I said really his first symptom that I picked up on was his behavior change. And even as a pediatrician, I might think, oh, mood swings, behavior change, maybe we should check his thyroid, which I didn't even do right off the bat. We didn't find he also has hypothyroidism. We didn't find that until after his diabetes diagnosis because they start looking for all the associated autoimmune diseases at diagnoses. So there's no harm in just asking the question. I think one thing I would like to hear from you as a specialist, right, and something that we're getting into now is how do you talk to your kid, or whether your child is the one with diabetes or maybe their friend has diabetes, they wear this tech, and so now this invisible diagnosis has an outward sign.
Mm-hmm.
How do you talk to them, right? They're curious. Kids are curious. They want to know. They're going to point it out, right? They point out kids who are different.
Sure.
So what would you say to those parents who maybe their kids have a friend with type 1 diabetes? How do you coach them to what kind of questions? How can you coach those questions? And then two, how would you coach the parents and the person with diabetes to answer that, to handle those questions?
Yeah, that's a great question. So, I mean, I don't have a book that I love yet on this, and that's like my superpower is having a book. All my fellow therapist colleagues will be like, "What book do you use for this?" Because like you can't see it, but I've a giant bookshelf behind me, with lots of books. I so I think the thing is that I think works best is honesty, right? I think factual information is the most helpful, right? When we're direct and it is just like, okay, so that outward sign is a continuous glucose monitor. And what that does is this, and this is how it works. And they also, maybe have an insulin pump, and this is how it works. And this is why it is. And to say, like with cancer, there's a book that I love that talks about why cancer happens. And basically the summary of it is that the cancer cells are having this party basically, and it says like they're not doing their job anymore, right? So they're more distracted on this thing than they are on what they're supposed to be doing, and then they kind of take away the space for the guys who are doing their job, which I love that kind of definition, because it's true of like there's something not going quite right in our body, right? The cells aren't working the way they're supposed to. I don't know that kids need all the details of things, but just like those cells aren't working right, here are the things to be looking for. Like if you see your friend do this, or if you're feeling like this, if you're the kid that has diabetes, to like ask these people for help. I think a lot of times telling the kids, like, here are your people, right? If you have something, you can go to the school nurse, you can go to your teacher, you can go to the principal, you can go to the gym teacher. And that means you're in the library and you feel like that teacher doesn't know, you go to the nurse, even if you haven't asked, right? Like, I think empowering them ahead of time, here's the plan. Then they tend to kind of push into that plan and feel good about it. And then if they see a friend, I think the speaking up part is something that I'm really trying hard to educate my own kids about, but also the kids that I get to impact, is if you see something that doesn't look right, speak up,
Yeah.
right? That is the right thing to do. And as parents, sometimes we're like you said, like, oh, somebody else is doing that. No.
Yeah.
Right. If there's 20 people that come and say, hey, this kid didn't look like okay, or whatever, as a parent, you're going to be like, yes, thank you. Like, or you're not going to be mad about that. You would rather someone say, and sometimes you're not with your kid. I mean, none of us are with our kids constantly because we go to work or they're at school or whatever. And so we do miss some things. And so something seems off. We want people to talk about it and say something about it so that we can do something about it. And I think that goes for so many different topics, but especially in diabetes. And I think it's just not making it scary, but just like knowing how to respond. And then you ask, how can kids talk about it? I think the key, there's not a perfect thing to say. I think it's about, what does that kid feel comfortable with? What do you want people to know about you? And I think what helps is a lot of times, regardless of what the situation is, educating when we start school, like as you go into elementary school, like let's say you had the diagnosis before you started school, you would educate your first and second and third grade by in kindergarten, right? Like you would do that. And then by the time you get through that, most of the kids know that you have diabetes, right? Like you don't have to keep doing that. But like you start middle school, there's new kids, right? Like I think those pieces, you start high school, I think it's saying like, hey, this is something cool about me. I have type 1 diabetes. This is what it means. I get low blood sugar or sometimes high blood sugar. If you notice that I'm sleeping, or you notice that I, am like jittery or whatever it is, like check in with me. Just ask me if I'm okay. And if I'm not responding, ask the teacher for help, right? I think whatever the kids feels comfortable. But I heard somebody say once that if you notice something about another kid and they can't change it in 30 seconds or less, don't say anything, right? But I think there are times where education is power, right? And so I think this isn't a time where I'd say, yes, you can't change your diabetes in 30 seconds, but there is an important element of education in this that kids around that kid should know about.
Right. Right. So if they're nodding off and falling asleep, or, they just turned around and threw up, those are things that are acute changes that we can change, right? Like if somebody's sleeping, we can check on them and wake them up. That's something you can change in 30 seconds, right?
Yeah.
So yeah, they can't change their diabetes. You can't tell them like stop being diabetic, but you can definitely coach them of like, hey, to be a good friend to somebody who has diabetes, you can be looking out for them in these ways. I think what we're running up against right now is that feeling of being different. It's really hard I think from this age all the way through kind of middle school and high school.
Yeah.
And so navigating that ownership of, yeah, you're different in a sense because you have type 1 diabetes, but yeah, that could be a really cool. Like, that's why we say you are so brave. Like, you are a warrior with type 1 diabetes. Yeah, other kids don't have to do what you do, but dude, you do that. You're killing it here, right?
Yeah.
Like, so trying to help him feel empowered, like you said, we try to give as much choice as possible.
Yeah.
Right now, those choices look like concealing his tech and not making it an outward sign. That's been new. That's something we're trying to navigate because you have to rotate those sites. So in his little body.
Yes.
But yeah, trying to give your kids choice where you can, I think is really important. And then kind of the verbiage that we use is, hey, you get a choice about a lot of things, but this right now, it's about your safety and your well-being. So I'm going to make that choice. That's my job.
Yeah.
And I think as a parent, please reach out, ask for help. This is not an easy, I'm going to go through it, like, not really a normal situation that most parents have to go through. So, you know, you're going to need resources that are maybe outside something that's typical, and that's okay. Please reach out, get resources, whether that's peer support of other moms or parents who are dealing with a type 1 diabetic child, whether that's professional help, like helping navigate those conversations and practicing the verbiage that you need to use, or processing the feelings of, man, did I do this to my kid? You know, is it, you know, like there's so many feelings wrapped around all of this. How could I have missed that? Right? So please reach out, please get help. There's so many resources and you don't have to do it alone. You do have a whole community to rally around behind you.
Yeah. I absolutely think there's a grief process when our kids get diagnosed with anything, especially when it's like one of those things like the celiac. I have celiac, giving it to one of my daughters. Like there is guilt associated with that, but then also like, hey, we can live through this. Like we can totally manage. Like I wouldn't have chosen not to have you simply because this is your reality. But it is hard. We definitely as parents feel a lot of feelings. And one of the things that you said earlier is like wanting to feel like you belong. I heard somebody say, and I loved this, and so I've kind of taken this, is like we were all made to belong. You were born to belong, but we weren't all meant to fit in. We don't have to fit in, but we are all made to belong. And I love that because like I think as adults, I mean, we know we've made it through, but like we're weird, we're different, none of us are the same, right? Like I think we all have quirks about us, like we all are different, and so like we have been able to find a group of people that support that. But as kids, we sometimes don't recognize how important it is to just, you already belong, you automatically belong, you're here, right? And you don't have to fit in. I think that's such a hard thing, is to go against the grain. But it's actually freeing a lot of times.
Yeah. And I think you asked me what I want parents to walk away from this. And I was just thinking about the first time as wearing my pediatrician hat. I work in pediatric urgent care. The first time that I had to give a parent and a child a diagnosis of type 1 diabetes in the urgent care after my son was diagnosed. And boy, talk about processes and feelings, that hit different.
Oh, I bet. Yes.
But it also was like really empowering. Like it was one of the most powerfully empathetic moments I think I've ever had in my life, to know exactly where that mom was sitting at. And I will say, from that experience, as well as the other times I've had the opportunity to help come and find a diagnosis for patients and families to be type 1, is that the most common question I get is, but can he still XYZ? Can he still play baseball? Can he still become an Olympic swimmer? Can he still work for NASA? Right? Like whatever this kid's pathway or trajectory, The answer is yes. It's yes. I would say the only caveat is that we had a really strong suspicion that our youngest was probably going to become like a Delta Force military operative. He has always been that tough, that determined of an individual. And I said, you know what, though? He can still be a civilian and work for another one of the 3-letter agencies, and he'll be just fine. Mm-hmm. So the answer is always yes. And that there are people living with type 1 diabetes who are astronauts, that are Olympians, that this does not limit your ability to do anything. It's just going to take a little different planning, time, and attention. Love it. I think to walk away from anything, I want to empower both people with diabetes and their caregivers that this does not have to limit you in any way.
That's amazing. Well, thank you so much for all of this. This is such a great conversation. I so appreciate it.
Yeah, I loved being on air. So hopefully we'll talk again.
Thanks again, Dr. Montalbano. That was such a great conversation. I'm so glad that we were able to get this information out there. I hope that you took something away from this, whether your kid has diabetes, whether you're concerned about your kid having diabetes, or you're just getting yourself aware so that you can support kids with diabetes. I would love for you to rate and subscribe to our show. Follow us on Facebook and Instagram, YouTube, and TikTok, and also keep sending us emails with topic requests for shows to accidentalexperts@gmail.com. Have a fantastic day. Some words from our legal team.
The information presented in this podcast is not intended or implied to be a substitute for appropriate professional advice, diagnosis, or treatment. All content, including text, graphics, images, and information contained on or available through this podcast, is for general information purposes only. This podcast makes no representations and assumes no responsibility for the accuracy or information on or available through this podcast, and such information is subject to change without notice. You are encouraged to confirm any information obtained through this program with other sources and review all information regarding any condition or treatment with the appropriate professionals.
What we're saying is, yes, I am a real therapist, but I'm not your therapist.